Just first of all, I want to say thank you for so many of you for coming today. And just picking up the comment Adrian made earlier, we are in a real tension because on the one hand, we committed out the back of last year's process that we'll be starting things earlier, and as you can see, we are, which is good. But also, I think we're trying to finish earlier, and therefore the pace we're trying to do things still feels very fast. So we are absolutely trying to straddle the tension between connecting, engaging, both nationally, but I think also very significantly locally and regionally, which is really important. So we're not going to be doing everything from the centre. So that's our key challenge. What I wanted to do was just talk to you about some of the themes in commission intentions, and I'll give you some helpful ones. But one of the questions, issues was sort of we've got a lot going on in the system, and I think it was Chris Hobson wrote in the HSJ. You know, look, the core ask is really stretching. Surely we've got to kind of knuckle down, nail down, kind of ruthlessly prioritise down to a few things and do those few things well, and just realise we can't do a broad agenda because the system is under too much strain to do that. And I absolutely have a lot of sympathy with that point of view. I think equally the challenges that we have both in being able to keep the wheels on from delivering quality care, be you a mental health trust, acute trust, but also being able to purchase and afford to buy the care in line with need is the joint challenge that we've got. So, and those things that are coming along that patients rightly might say, well, if we've got a new drug that can get to 97, in fact, the latest Hep C drug trial had 100% cure rate from MSD's latest trial. So something like that comes along, which is such a step change from an interferon-based regimen. We are probably naive in thinking that the public are going to say, well, we understand you're a bit busy, please come back to it in a few years, because if I've got that disease and that problem and I could be progressing towards end-stage liver disease, then frankly, I wouldn't be happy to wait. So that's the real challenge that we have. I've worked in a turnaround environment, and I think many of us are probably in that, be it in a provider setting, a commissioner setting, and I think nonetheless there is one of the challenges is do you get initiativitis, and one of the tricks is how do we make the initiatives that we're doing actually deliver across multiple agendas, because that stops initiativitis and we can join things up a bit better. And I think as we're thinking about our commission intentions, one of the things we thought about is, with the Carter review happening, there are an awful lot of things that are actually going to be put into place to drive a 4-year programme of change across the system. And wouldn't it be great if, rather than having a whole set of commissioner priorities here and the Carter stuff over here adding together with two kind of compounding programmes, wouldn't it be great if we could drive the change in such a way that we yield both the productivity and efficiency gains that we need to keep the wheels on and the transformative effects that we also need so that we close those 3 gaps that Jonathan was talking about. So we've really thought quite a bit about that and how can we make sure that we harness some of those things and do them in a joined-up way. We're talking to NHS Improvement, to the Carter team in particular, about how can we do that, and you'll see as we go through. So I'm going to talk about that. It's not all two sides of the same coin. So there are some things that we're doing that fall outside of Carter's remit, as you'd expect, but there's a lot that we can combine. So just going to set out some emerging thinking about our key themes from our commissioning intentions. I'm hoping that you will appreciate the stage in the process. One of the things I think which was said around that when we were talking, when just washing up from the last commission round was, please talk early. And I think by doing early, please understand that these are very much where we're at with our emerging thinking. It's not like we've got this fully drafted document ready to go and this is the big reveal and it's all written down. It's not that. We are having to move at a credible pace. I'm looking at some colleagues around the room working and say, cancer and blood and infection program care, and actually, there's a lot of rapid work being done, but the whole point of today is not bringing to you the end points of that work, but actually talking about some early thinking. So that has some health risks attached to it. So one is that this is not going to be comprehensive, and therefore there could well be some things in our commissioning intentions that aren't covered today, and that's the reality of how we're engaging across the organisation, and with Simon Stevens and the top team about that. And also, I guess, things could change significantly, either from feedback from today, but also from other factors going on, say, for instance, how national service priorities have been taken forward, the implementation plans for some of those. So that's the caveat, really, is that, but on the other hand, you might say that's quite positive. So what we're not doing is kind of showcasing a baked cake. What we're saying is, here are some ingredients that we actually think will combine really well. And actually, you may say, yeah, they're okay, but you need to add a bit more of that over there to get this thing to where we want it to be. So it is formative. But also, we've got this tension that what we're unable to do easily in the climate that we're in is we've got this massively compressed timeline that gets us out of the loop of doing things at the last minute. So in a sense, we're doing things very quickly to not be at the last minute. The luxury and the blessing about that will be, imagine being in a situation where you're fully signed off your contract, you totally understand your sequence, you understand your improvement goals, your trajectories, you've briefed your clinical teams in January, ready for starting in April. I mean, that would be just so different to what we've done every year since I've been in the NHS, where actually we're scrapping right up to the line, and then people are saying, oh, well, we're now in the middle of May, yeah, but what's the target? Yeah, well, we're supposed to be delivering from the start of April. Well, we're already behind on that. So there is a real win, and we've been, in a sense, there's a bit of be careful what we wish for, because we in Specialised have been lobbying as hard as anybody in NHS England to say we've got to bring the cycle forward. We've got to allow the preparation, the start-up time for our trusts, our providers, to be able to hit the ground running in April without feeling like it's, that all the prep time has been swallowed by the negotiations. So it's a problem we have, but it's a good problem to have in a sense that it will get us out of some of that cycle. Just some of our draft commissioning intentions themes then, just to kind of give you a bit of an overview. So Jonathan's already spoken about the centrepiece really for our intentions, which is that our strategic framework really talks about making coherence about place-based care and the SpecCom element of that, about building on the work that's going on and aligning with and publishing at the same time as STPs in their next iteration, and also using the process to make further progress or set up the potential during the life of the contract to make a transition towards new models of contracting, commissioning and provision. So that's really a key heart of things. But also, there are some very specific changes put in place in the next 2 years, set out, for example, in the mental health implementation plans recently published, and also delivering world-class cancer outcomes, those strategies. We were talking with the Chief Scientific Officer as well this week about the need to really start to see some of the changes around personalised medicine, the personalisation agenda. We already last year, you remember, put in place something whereby new molecular diagnostic treatments will get 3 years of direct commissioner funding before they get incorporated into episode-based tariffs. And again, there's more change in that area, which I'll touch on very briefly. So they're things that you would obviously expect to see. And also I put in there, you know that we embarked on a 3-year rolling programme of clinical service reviews, and that is changing things, for instance, be it intestinal failure services, stereotactic surgery, some work going on with CAMS, Tier 4, secure mental health. There is a whole programme we've already previously announced, and we've committed to that being a rolling programme. So there are some new things coming along out of that, for instance, out of the Children's Congenital Heart review, doing more focused work on PICU, for example, that's coming out of that. So you absolutely will expect that there are some things where what happens at a place-based setting needs to be complemented by something that takes a service-based cut. And we will continue to do that, both sometimes nationally, very often regionally and sub-regionally, linking to those tiers that Jonathan was talking about. We also have what I've kind of called unfinished business, and one of the key things really about our commission intentions, I've just read the last 3 sets, and one of the things that's been quite helpful about that is that there are some things where we've been making progress, we've been talking, we've been moving things along, and actually some of the things that came out when commission intentions came out last year, some people saying, blimey, this is a shock. Well, it wasn't such a shock because it was a 3rd year in a row we'd particularly been saying that, but we were building on an approach that we'd laid before. what we really want to do is land some of those things which are in progress, and we recognise we've committed to some big changes. CUR is not like an overnight change where you flip a switch. It's a transformational programme, and we started that with something very permissive about 3 years ago with a small incentive. We moved that up. The year previously gone, we did early implementer grants to give, really get those early adopters additional resources to focus on. We've moved now up the curve. We're at around about 30 hospitals actually, or 30 health systems going live, and three CCG-based systems as well, really grabbing kind of an area-based approach. So we're moving up that curve, but we're way away from what I think was aspired to in Basden, which is just, it's the way of doing business. And we know that in order to commit to some things that we're doing, the thing that doesn't help in a healthcare system is a stop-go policy where we're heading down here and then suddenly you do a handbrake turn and we go completely back in the other direction. We're trying not to do that, but we're also recognising that that means some of what we've been talking about, you know, landing accurate data so we understand and can properly pay for the right medicines for the right patients. We're still not there. We still haven't implemented e-pharmacy everywhere to drive some of that. Things are getting better, but they're still far from where we need to be to know we've got grip and control. So some of the things that we've done, we have to follow through, and we will see some of that in our attentions as you expect. Helpfully, I guess, there are some things where we'll just be able to say them succinctly because they still matter, and we don't want you to read into silence, but actually some things are kind of getting pretty established now. So we don't need to say in quite the same length we might have said a year ago, 2 years ago, and that should free us to see the wood for the trees and the things that are definite. There is really a strong medicines emphasis going to be coming in this, as Jonathan alluded to, in these commission intentions. It's not entirely new, but there's a significant context. So, for example, we know that the way that we might share gains or realise benefits around medicines, you know, a couple of years ago that was going to be affected by marginal rates of tariff and things like that. Well, that's all on the back burner. We put it on the back burner last year. We put it on the back burner for the next 2 years as well. And actually, we've also been working with the Medicines Optimisation CRG over the last 2 years, and we kind of paused on some of that. But we are really keen to drive change in the way that we deliver on that. But also linked to, as Jonathan said, accelerated access review, and we've been doing in SpecCom a review of high-cost drugs more generally to say, how do we get ourselves to the best point on the curve that means we're getting the best value for every pound that we're spending that's going into medicines. Moving on to the point that I want to really spend more time on this presentation is really with Carter coming out. And again, as I've said, what we want to try and do is, rather than compete with a whole set of other things to do, is try and connect with that agenda so that the agenda is more manageable for the system to kind of deliver. So that's what we're trying to do. You'd expect us to do most of that, you know. So with the medicines, for example, if a third of our spend as SpecCom is growing at around 11%, if we don't do something differently, well, guess what? With 4% growth in the successive years, we better do something differently, or we'll all have spent all the money without even buying demographic growth, your point, Siva, earlier. So we have to do more in that. So let's just talk a little bit about some of these areas. So I want to talk a bit about the world-class cancer outcomes and personalised medicine. So two things that I want to draw your attention to thematically is, so one is that we talked about the direction for molecular genetic testing, but we have talked about a move from kind of single markers, your Oncotype DX type test or your ALK test, to really moving to more kind of panel-based approaches as we build on the work that's been done on the 100,000 Genomes project. So that's a clinical trend that's going to change, and actually is going to mean that the way we do some of that is going to change over the course of this commissioning round and the 2 years that follow it. So we want to signal that both, and that's partly because commission intentions are useful for you and your staff, but they're also really poured over by industry. And actually, it's really important that we say, knowing that panel testing is coming on, don't invest loads and loads of money into more and more individual markers because they'll be superseded. Now, there'll always be a role for some of that, for complementing that, I think. But so it's not kind of black and white. But we want to give that message early out to the wider system so that what is coming along is, as Jonathan said, the stuff that really will make a difference to patients. And actually, This stuff is absolutely key for us. The more we can, for instance, where we can target those patients who will benefit from chemo following breast surgery, for example, in the case of Oncotype, we can target them way better than we could before. Then that means not only do we change people's mind who weren't going to have chemo, and then they'll get better survival rates. We also tackle those people for whom it will give very, very marginal or no benefit. And actually we can assure them that actually they're in a position where they're confident to carry on without subjecting themselves to additional toxicity that they don't need. And that's really good for the whole system as well, because the more we can personalise and target treatments to those people for whom they're most effective, that will really help us with the money as well as the quality. The other thing really of note in cancer, which I want to raise with you again, is we are grappling with, you'll know from the cancer strategy, there is a real ambition to replenish and replace the LINAC kind of footprint of this country to make sure we're using the latest kit with the latest features, because actually it can do things that early kit can't do. But we have a structural and system problem, which is actually there is not loads of money sitting set aside for replacement of capital kit in the sector right now. And the way we've certainly had tariffs work has not really led to separate funding streams around that. So we're trying to grapple with how do we support that transition? And should we, for instance, in the way that we do payment for radiotherapy, separate the way we fund the ongoing activity that's done versus the way we fund the ongoing cost of capital, so that there can be a more planned approach to transition. As I say, early days, these are questions, not firm proposals and solutions that we're trying to raise, but we want to talk to you about them now, because actually they're going to happen through the lifetime the contracts are about to put in place. So we wanted to make sure that that's flagged to you. Mental health, I want to particularly focus on some key things around mental health again that are part of our intentions. So you will know from the planning guidance from last year, we've got some pilots looking at doing the secondary commissioning. So for a secondary mental health provider commissioning tertiary mental health services, we have six providers going through that process. And again, we're going to realise that through this commission round, but much more widely than that. A very not very high profile, but fantastic amount of work has been done, led by colleagues in the forensic sector as well as commissioners over the last 4 years, around how we can really make more fundamental changes to the way that we deliver funding for secure mental health. And you'll see some of the building blocks on this parameter here. So we have a case mix classification that can help us understand what's not levels of severity. We've already got the national mental health clusters, but actually the work's been done to understand specific pathways that interact with those clusters that are much more correspond to how much resource is needed for patients than the clusters do alone. So for secure mental health, we're on a footprint where we're getting to a point we've got the tools to actually do something that moves us away from either block contracts on the one hand or per bed day contracts that are very crude on the other. We're looking at that, and the team that have done the work on that have really done a lot of work around understanding what might be a facility payment for those services, because actually you have some always-on staff capacity that is going to be needed. And as part of making sure we've got that capacity in the right place, we should probably be committing to saying we're just going to cover that. Because we know that if we move money away from that, you'll end up in a financial pressure that actually could compromise the quality of and sustainability of care for the patients who are in those units. So that's the fundamental shift in how we would deliver and fund services. We're looking to move away from the bed day or the block approach to a more spell-based payment with a really clear front-end payment that's about assessing patients in their first 3 months of admission really well. And then specifically at the back end, looking at an approach specifically to supporting discharge and resettlement. So there's more of a kind of handshake with CCG commissioned care, if you like, and really making sure that resources are put into that part of the episode. And then a middle episode on treatment and recovery that will link to this case mix classification, so that depending on the type of patient it is and type of pathway they're on, whether they're treatment responsive or not, that actually your payment can be appropriate to dealing with the acuity of patient, and also motivate and incentivize those things that will lead to faster recovery, in line with the mental health strategy about a recovery-oriented agenda and relying less on inpatient care. So that's a quite significant change. You will be pleased, I guess, if you're mental health providers in the room, to know that what we're not proposing to do is kind of go, ta-da, and then say, please put this in your contract. Here are the numbers, here are the prices. It's all there, kind of from a standing start right now. But what we have said is, as we go through this service review that we're doing on secure mental health, we will look to embed this type of approach, so that as we create the new patterns across the country of where care is delivered, we also change how it is delivered and make sure that the funds flow in the right way and tackle some of what can feel a bit dysfunctional, I know, at times, in the way we have commissioned care in the past and the inconsistency of that. And hopefully that will really complement some of the wider work that's been done and has been announced in the payment system around CCG commissioned care as well, that's in the tariff document. So just talking a little bit about the medicines optimization, so the life cycle of a drug price is something we've been very much focused on. So from getting a great deal right at the front end, at the point of entry to the NHS, be that highly specialised treatment that can get delivered at a much better value, be that stuff coming in, the reforms we've done for the Cancer Drugs Fund to make sure that we're really taking on drugs that can plausibly be cost effective, and sorting the evidence out for that during that kind of period of being in the CDF before they become routine commissioning. As well as, I think, when new medical technologies come along, when other interventions come along. So it's not just about medicines, but specifically we know that things come in at a high price. This is true in many industries. Things come in, they can be expensive, then over time, the new indications for that drug expand. There's then maybe brand-to-brand competition, and then over time we get generics coming in, brand to generics, and then ultimately fully generic. And we know that there's that life cycle. And actually, something that our primary care colleagues actually been doing for a long time is really being quite systematic about getting the right treatment for patients and switching patients right through that process, so that we can always be assured we're using the very best value. Because we can try and drive out and there's a commercial medicines unit and other can drive out value from that process. But actually, we've got to address what we do on the ground so that we know the patient's using the right treatment. And so there's a whole raft of things, I think, including new relationship between NHS England and the commercial medicines unit that we'll be working on to try and see more innovation in the way that we can land treatments in the NHS and really tackle that 11% year-on-year growth by doing things differently. Wanted to talk then about Carter, so focusing on the really a kind of mainstay I think we want to use. And one of the things picking up was said earlier is, one of the great things about Carter is it brings together, we have two different viewpoints you can see on here. So we have the kind of purple is kind of the, we can see things from a very provider-oriented perspective. It's about CIP. I've got to deliver this, otherwise I can't deliver my service within the income, and that's got to be the focus. And it's going to affect my provider costs. It might or might not affect commissioners' expenditure, but that's going to be the focus. Or we can just take a very commission-oriented approach, which is, well, this is about QIP or improving value. I've got to preserve my purchasing power, and I can only do that if I can, for instance, get people through a pathway with fewer episodes, if I'm paying per click on the turnstile. And obviously some of the stuff that's been announced around, for instance, having a single reformed approach to outpatient follow-up, for instance, gets at some of that change. But ultimately, I can just take a commissioner approach where it's all about follow-up ratios, acuity rates, and things like that, and does nothing to deliver on the underlying challenge that we've got in the provider sector, which is how do we get the outputs for the inputs that are available. The great thing about Carter is, you see those two things at the bottom, I think are really, really come through, which is what we can all agree is that cost shifting probably isn't really efficiency. And income generation actually isn't really efficiency or solution either, even though those things could characterise some of what has happened in the NHS in previous years. And mostly initiatives kind of straddle a bit of CIP. They might reduce unit costs, they might also affect provider income in some way, they might affect purchasing power for commissioners. And actually, the best thing we can do is deliver on something that delivers for all of that, rather than just get into our tribal approaches of just delivering our own bit and saying, well, I'm doing my bit, why aren't you doing your bit? And I think the approach to Carter is very much sweeping on that. So, for example, what's happening with cost per weighted activity unit is drawing on whether it was a commissioner-funded pass-through payment or whether it goes to the provider bottom line in the national tariff. Doesn't matter. You're being held to account for delivering all of it. And so I think that's a very healthy place that we're at. And what we've got to try and do is make sure that our agenda delivers for both of us and not neither of us, through that general, not one or other of us. So for those colleagues in the room, I know many of you in the private sector would be super familiar with Carter. I know not everybody here is from that, but just an overview. Carter's focusing particularly on 6 areas to try and address variation in hospital inputs, in particular around about £5 billion by 2020. And as you can see, a lot about the clinical workforce. That has a real correlation to time, going back to the COR stuff we talked about earlier. And those are the areas which I won't talk through, you can read them on the screen. So some real specific areas that have been identified to tackle, and a whole raft of recommendations that come out of that. And we've got some sessions this afternoon on that. So some of the recommendations, this new weight metric, the spend per weighted activity unit, particularly around inpatient care, to have a comparative cost per spell, be that clinical time and be that clinical cost, or be that non-pay cost, be that estates footprint related cost, all of those things expressed in that way, and the use of benchmarking of those numbers to really drive things. A major emphasis you'll see on NHS improvement. They're gearing up a whole team to hold system to account for this in a way that what we want to do is think about how do we complement that, so you're not getting one steer from NHS improvement driving things in one direction and yet another steer in your contract saying, yeah, but I'll be punished, I'll be penalised if I do it in that way. We want to try and make sure that these things pull in the same direction. Big focus on the hospital pharmacy transformation programme, as you can see, linking really strongly with our focus around medicines optimisation, around the very best way of delivering, for instance, the best value dispensing route for every medicine, so we don't have money leaking out in charges, and frankly, giving money back to the Treasury that is great, but you know what? It'd be much better if we could recycle that and treat more patients and actually achieve more with that, achieve more health gain with that. Pathology diagnostics, reforming procurement and the purchasing price index. And again, the work we've got, you can see at lunchtime and beyond on, for instance, the centralisation of device supply chain is going to deliver for many of you in the room a big chunk of what Carter is asking you to do for a significant chunk of spend, which is great because as we've been talking to colleagues from trusts, having time freed up to work on other categories, knowing that you're going to be performance managed on those, and knowing that we've got a single national process driving to the lowest possible cost on devices that you can benefit from, and know that that bit's in the bag and will help you look good and help bolster those metrics, I think is really welcome capacity creation, hopefully, in the system. A real focus on outcome variation and the getting it right first time programme. So that particularly keys into our agenda around doing things, as Jonathan said, that long tail of provision. And actually, some of the work that Tim Briggs and his colleagues done, that is really using a very similar agenda. So earlier discharge and step down, massive component and a real requirement for a strategy that straddles the whole health system. We've been doing delayed discharges since I joined the NHS, quite frankly, so that's not new. And yet, some of where we can really see the bottom of the iceberg from some of the new tools we're rolling out actually will really help deliver on Carter in a way that would be really challenging. You know, some of the numbers we were seeing earlier were 30-40% of bed days potentially needing to be in a different setting or even at home. Actually, systems have been using those tools for 10, 20 years. They're in single digits for the numbers in the wrong setting. Imagine if you're in single digits, guys. How many, 30% of your beds just weren't needed anymore. What would that release in terms of the time per patient, the clinic, all those metrics on Carter? Absolutely really helped. So, and obviously the digital hospital. So we've been really focusing on that, and you can have this slide, but essentially what we want to think about is, you know, we've been looking at for a long time now, we've been talking about and making limited progress on how do we really clinically service redesign those services that look like they're outliers in terms of either they're loss-making for you or their unit costs look to be outliers relative to others. We can see others actually seem to be achieving spec compliance and yet delivering at a much lower unit cost. Well, do you know what? That's something that Carter's going to drive anyway through the system. We'd like to work together on that. We recognise all the stuff that's in tariff, all the gains will go to you as providers, and in the long term, I'm sure they'll come back and help with purchasing power in the future. But you know, around 40% of what we spend isn't nationally tariffed. And actually, we've got stuff where you want us to pay more for certain services, that's fine, but we're going to need to pay less for other services. We want to get to a point where you can feel confident that your services are running in the most efficient model they can and that you're fully reimbursed for that most efficient model. And there's a real win for us to drive on that. We've talked about CUR and getting that to business as usual. And again, we expect that we're going to see CUR is going to be, over the next 2 years, we're going to get to a point where CUR is just part of the service specification for delivering specialised services. Whenever we do a clinical services procurement, one of the criteria will be, will you commit to actually using CUR tools so that we can be assured on an evidence-based basis that the patient's in the right setting on the right day every time. So that's our direction of travel with some of these things. But we know that along the way, they're going to deliver on the Carter review. They're going to deliver that lower length of stay. They're going to deliver the step charge and discharge measures. They're going to help with that resources per weight activity unit as well. You can see right the way down that agenda that a whole raft of what we want to do in our commission intentions really is designed to say, if we do these things actually, then it will also deliver on those same things that you're going to be held accountable for a 4-year milestone-based benefit realised programme that NHS Improvement will be holding you to account for on a monthly basis. Wouldn't it be great to do it all as one programme and hit it all together? That's our goal. So some concluding thoughts from me on this. As I've said, many of the new and the existing asks, we can combine them if we can agree that kind of structured change programme and get better at following through on it. Do you know what? We've had, in 1-year contracts, we've had SDIPs for a long time. And do you know what? Service development improvement plans, sometimes they really drive change, and other times they're a big long wish list and everybody looks at it just before renewing the contract the next time, and we've really moved no further forward. Well, the Carter programme won't let us do that. And actually, we wouldn't want to do it anyway because we're not going to deliver the sustainability Jonathan talked about if we don't drive that. We're looking, obviously, at a multi-year contract and the framework, and that does give us an opportunity, I think, which is really good. Often when we're talking about QIP and cost improvement plans, we tend to freeze out the things that won't deliver immediately. And so we're very focused on very transactional stuff, and as Adrian was saying, some of the pass-the-parcel type stuff, because actually we're thinking about, well, the things that were really transformative, they're just not going to deliver this year. They might even cost slightly more this year. They'll be breaking even next year. They might be saving the year after. And I think a multi-year approach gets us, and particularly both with the contracting round and with Carter, into a 4-year trajectory. So if we can balance things we've got to do in the short term with things that we can have a bit more of an open mindset on the long term, we want to do that. And as Jonathan made very clear, those gaps we talk about in health and wellbeing, care and quality, and in funding and efficiency, it's the same agenda. So our agenda with our CCG colleagues and the agenda for specialised care, it's all the same agenda. So that's what I really wanted just to lay out for you. I guess in a theme basis, you'll see it's not like loads and loads of detail and drafted words, but that's the point. If we get these ingredients right, the broad shape of what we're trying to do in commission intentions, we hope that we can be positioned in such a way that we can deliver more together as we go forward and hopefully land things by December, hopefully actually be delivering on things by April for once and not be behind the curve, and have the time to follow things through such that we're in a good place for year 1 and year 2 of Carter in the contract round. And actually, do you know what? Where we need to commit for longer, we can commit for longer. We can jointly commit to not freezing things so that once a contract's in place, we're not prepared to evolve because we know we're in a dynamic system, in a dynamic healthcare, but we'll be able to transform together over a longer frame. Thank you very much for listening.